To questions. So without further ado, I'd like to start and welcome Bill Albino, the President and CEO of Smart Systems for Health Agency. Welcome, Bill.
Thank you very much. I'd like to thank Rogers and Stefan and Brad for inviting me today. I'm delighted to be here. The theme of the roundtable, I guess, was where are we? Who's accountable for the disparity between the promise and the reality? And I think what I'm reading into that description a little bit is that there's a little bit of growing disappointment with the whole eHealth agenda, and a little bit of skepticism creeping in, a little bit of cynicism creeping in. And as I'm deeply involved in it and have a chance to speak to many people on the subject, I sense that there is a little bit of that spreading. So what I would tell you today is that I'm a complete optimist on the subject. I believe that the whole eHealth agenda is gathering momentum and it's gathering direction. And I believe it ultimately will deliver on the promise. I think we need to do a lot more from inside on setting expectations and communicating what's happening. But as I said, I'm an optimist, and I'm going to just give you some of the reasons why I am such an optimist. I'm going to start with my own organization, which is Smart Systems for Health. And we've been busy and are still busy every day putting together the Smart Systems for Health network. Now, any eHealth system is based upon a couple of foundational elements, and one of them is the network. And in fact, the SSHA original charter was to develop and build a secure messaging infrastructure, or a highway system in which electronic health information could be exchanged in a high-performance, secure, and managed environment. And building networks doesn't get a lot of attention. It's not like building skyscrapers or building physical plant. You can't see it coming together very well. But what I'm here to tell you is that we're doing, I believe, an outstanding job of building what will become the largest MPLS managed network in North America to serve the eHealth marketplace here in Ontario. We're about 40% of the way through the build. We've built the core, we've built most of the access points, but we have built what I believe should be well understood as an extremely capable, high-performance, reliable, secure network, which will be a model. It's now the largest network of its type in Ontario. It'll soon be the largest network of its type in North America. And ultimately, it will connect all 150,000 people, estimated 150,000 people, within the health.
Thank you, Bill. Now for our next panelist, Roger Gerard. He's the Integrated Vice President and Regional CIO of the Niagara Health Systems. Roger?
Thanks, Stefan and Bill, for your comments. According to the theme, being consistent with the theme of this discussion, what I'm going to do in my comments is try to address three major topics. The first one will be an assessment of where we are from an EHR or an eHealth perspective. Some comments on that. Secondly, the question of who's accountable. I'd like to maybe make a few comments on that, and then leave you with, at least this part of the discussion, with four key messages, things that I see, just observations of mine in terms of where the challenges lie in front of us. First of all, then, in terms of where we are, from a status point of view, I just picked up the magazine. This is actually a Rogers publication. I'm not being paid to give a commercial for Rogers, but this is Canadian Healthcare Manager. And in their last edition, they actually say that we're a B. They don't aggregate the score, but there's an A for diagnostic imaging, and there's a whole bunch of Bs for all sorts of stuff. I found it interesting that public health infrastructure was a B minus. I always thought Ontario was doing a better job than a B minus in public health. But in general, they're giving us a B, which I guess is not a bad score. You know, when I was going to university, if I had a B, I wasn't entirely unhappy. I got smarter later in life. So essentially, as in general, there's a sense, both in this article, although it's at a very high level, obviously, and it's not enormously scientific, that it's not bad. It's not great. Boy, do we wish we would be doing better.
Thank you, Roger. Now for our next panelist, Dr. Chris O'Connor. He's the Director of Medical Informatics, Trillium Health Center. Dr. O'Connor.
Okay, great. Mic on. Okay, great. Thank you very much. I'd just like to follow up on your comments about eHealth and dropping the E. I think from a clinical perspective, all that really matters is quality and safety and taking care of your patients. Nobody does CPOE or EMR, any of these things. They're not good they're not goods in and of themselves. They're only good to the extent to what they can do. So in terms of engaging the clinical community, that's really the hook there. The other flip side of that too, and which I think the clinical community often misses, is that you can't talk about quality and safety and care delivery without talking eHealth at the same time. They are completely linked with each other. So they really, I think, are merging, they're becoming the same thing. They're becoming almost completely indistinguishable. So I'm going to speak a bit in terms of today's theme. I'm going to speak about, the sense is there was a promise, a feeling that maybe there's a gap, the reality, where are we today, and then a question of accountability, and I'll speak about who I think is accountable or who plays a significant role for that, how this came to be, and sort of a way forward, where to go. So in terms of where the promise is, went into practice back in 1990 as a family physician. And I think back then, I'm going to take that sort of as my benchmark. Back then, I think, I said, well, what was going to be up there, 16 years from now? I think there was a feeling that, it would all be computerized. We would have universal access to information. And there was a feeling back then there'd be a lot of computerized decision support. Computers would be doing diagnosis for us. They'd be helping us treat. I think it was a pretty rosy picture. So where are we? 16 years later, how are things? What's reality like? It's interesting. The chart is still mostly paper in most clinical environments. Ordering is still paper-based in the vast majority of hospitals on our institution. Clinical notes remain mostly unstructured. We communicate using pagers. Physicians overwhelmingly still have pagers. You could take a physician from 1990 and plop them down in a family practice office or a specialty office for that matter. There'd be lots of new drugs and new medications. They wouldn't have a clue what they were or what to do with them. But in terms of the process of care, like how they were going to run their office and what they were actually going to do, no problem.
Thank you, Dr. O'Connor. Our next panelist, Bill Pascal, is the Chief Technology Officer of Canadian Medical Association. And Bill?
Okay. I'm an optimist, but I'm also a pragmatist as to doability. And I'm going to really emphasize the pragmatic side of me. And I'm just going to give you a slightly different take on what all my three colleagues have said. I'm going to exaggerate a bit, but I'm doing it for a purpose because I have a tendency, we seem to forget, I think, or don't pay attention to some of the irritants and some of the issues out there that if we don't work with it well enough, we risk not disabling this initiative, but creating unnecessary irritants that maybe slow it down or divert its attention and slow down what I call the return on value that we can all get out of this. And it's an agenda that I see being characterized by a series of dilemmas. So let me talk a bit, and then I'm going to sum up what I see the dilemmas that we're all confronting. And it doesn't matter where you are in the system, but we confront them. I was around when we actually put together the first report for ministers on putting in place an IT agenda for Canada. And at that time, we didn't talk about the EHR. We talked about trying to enable business processes of care by intelligent application of IT to support processes, etc. It was only after that that the EHR came into being, and we made this leap of faith that the EHR was going to start to help us really get there. And as Richard has said, we called it the Holy Grail at that time. But the problem I have with the focus on the EHR is that we've got an agenda that I believe is far too biased to technology solutions and not to supporting the end users in their care processes. Now, once again, I'm overemphasizing here, but I raise it because as I've talked to all the CIOs across the country and I read their strategic plans and I take a look at what they're doing, there's a lot of nice words, but fundamentally when I cut through all the stuff that they've written, it's we've got some technology and we're going to get on with it. And